Hello everyone, this is Dr. Saurabh Sahi and welcome back to my channel, Doctor's Storyboard. So let's start our DHA GP notes, the extracted version of Master the Board. Continue with the part 1, gastrointestinal bleeding. Most common cause is ulcer disease. Most common cause of lower GI bleeding is diverticulosis, other angiodysplasia, polyps, cancer, inflammatory bowel disease, hemorrhoids, upper GI bleeding with rapid transit from high volume. BP assessment is important in GI bleeding. Ischemic colitis present in left lower quadrant pain, it spares rectum. During GI bleeding, we have to replace fluid. We have to check hematocrit, platelet count evaluation also very important, and PT-INR rather than to do endoscopy. Other diagnostic tests of GI bleeding includes nuclear bleed scan, CT or MRI, angiography, capsule endoscopy, ECG and lactate. So what do we have in the treatment option for GI bleeding? In the case of GI bleeding, we can give fluid, octreotide, PRBCS, that is platelet rich blood cells, PPI, fresh frozen plasma, surgery and platelets. And what is the action of octreotide in varicose disease? It decreases the portal pressure. And banding is also another treatment in esophageal varices. TIPS, that is transjugular intrahepatic portosystemic shunt, that decreases portal pressure when octreotide and banding failed. And interestingly, propranolol prevents subsequent episode of bleeding in varicose disease. So when there is antibiotic associated diarrhea, don't give vancomycin. Fulminant Clostridium difficult, meaning high WBC, metabolic acidosis, high lactate, high creatinine. So what are the criteria of fulminant Clostridium difficult? There should be high white blood cell count. There should be metabolic acidosis, high lactate and high creatinine also should be there. Now let's come to celiac disease short notes. The most common cause of celiac disease is malabsorption. Rare cause of fat malabsorption are tropical sprue and Whipple's disease. Dermatitis herpetiform is associated with celiac disease, almost 10%. And let's see the sign and symptoms of Whipple's disease. Arthralgia, pain in joints, neurological symptoms are dementia and seizure. There is fever and lymphadenopathy as well. And treatment is ceftriaxone followed by cotrimoxazole, TMP/SMX, that is cotrimoxazole. And unique test of Whipple's disease is anti-tissue transglutaminase (TTG) test, anti-endomysial antibody, and IgA anti-gladin antibody. The most accurate diagnostic test of celiac disease is small bowel biopsy that shows the flattening of villi, and it is very important to exclude lymphoma. Treatment of chronic pancreatitis, enzyme replacement. Treatment of Whipple's disease, ceftriaxone, cotrimoxazole, as I told earlier. Celiac sprue, the treatment is tetracycline and cotrimoxazole. And celiac disease treatment primarily is avoid gluten containing food. In case of celiac disease, rice and wines are safe. This is very important question which might be coming in DHA as well. And the xylose test is done to differentiate pancreatitis from bowel wall abnormalities. D xylose test is normal in pancreatic disorder. Gastritis is also caused by portal hypertension. Some features of gastritis: manifestation and volume of bleeding. In coffee ground emesis, there is 5 to 10 ml volume bleeding. In M positive stool, there is 5 to 10 ml, and in melena, there is 5 to 100 ml. Testing of S. pylori: endoscopic biopsy, serology, urea C13 or C14 breath testing, S. pylori stool antigen, and treatments are PPI, S2 blocker, example ranitidine, sucralfate, antacids. Stress ulcer prophylaxis is indicated in mechanical ventilation, burn, head trauma, and coagulopathy at the rate of SBMC, that is pneumonics. Please remember, stress ulcer prophylaxis is indicated in mechanical ventilation, burn, head trauma, and coagulopathy, plus sepsis as well, because this question will also be coming in exam. This is also important notes. Alcohol do not causes ulcers. They delay the healing of ulcers. Same like smoking. Cancer is present in 4% of those with gastric ulcer, but none of those with duodenal ulcer. Duodenal ulcer associated with H. pylori 80 to 90%, and gastric ulcer associated with H. pylori 50 to 70% of the case. And treatment of H. pylori: PPI, clarithromycin plus amoxicillin. Who do not respond, treat with tetracycline and metronidazole. Last time I mentioned about the triple therapy in part 1 lecture. Actually, there is quadruple therapy as well. In quadruple therapy, we would use bismuth for resolution of the treatment resistant ulcers. Non-ulcerative dyspepsia is epigastric pain with normal endoscopy. Gastrinoma is often associated with diarrhea because acid inactivates lipase. Gastrinoma is associated with a massive increase in number of somatostatin receptor in the abdomen. Somatostatin receptor scintigraphy, nuclear octotide scan, is combined with endoscopic ultrasound to exclude metastatic disease. Gastroparesis is an autonomic neuropathy leading to dysmotility. Diabetic patient with abdominal fullness, intermittent nausea, constipation, bloating resembles the diagnosis of diabetic gastroparesis. So when the patient is having diabetes and they complain abdominal fullness, intermittent nausea, constipation or bloating, then we can predict diabetic gastroparesis. The initial therapy for diabetic gastroparesis is blenderized food, restore fluids, and correct potassium and glucose. Metoclopramide cannot be used permanently because it may cause dystonia and hyperprolactinemia. Gastric pacemaker is used in gastroparesis after treatment failure, that is electric stimulation. The most common cause of GI bleeding is diverticulosis. Other causes of lower GI bleeding is angiodysplasia, polyps or cancer, inflammatory bowel disease, hemorrhoids, upper GI bleeding with rapid transit from high volume. Irritable bowel syndrome is a pain syndrome that can have constipation, diarrhea or both. In between the lecture, I would like to tell you that here I am discussing so many diseases, but it is coming as a notes, short notes, not detail. Because I told you that this is an extracted version of notes from Master the Board, and I am mentioning especially for exam point of view. So these are short notes. If you want to know the detail of the disease, you need to see the big books like Davidson, Clark and others. So now comes IBS. IBS is not associated with weight loss Also, it is not associated with blood or WBC cells in the stools. Treatment is hyoscyamin, dicyclomine, peppermint oil or TCAS. Treatment of IBS. If it is associated with diarrhea, then we can give rifaximin, alocetrone, iloxadoline and probiotics. And if it is associated with constipation, then we give fiber, polyethylene glycol, lubiprostone and linaclotide. Symptoms of irritable bowel disease: arthralgia, uveitis, iritis. There are also some skin manifestations like erythema nodosum, pyoderma gangrenosum, sclerosing cholangitis. Please try to read about erythema nodosum and pyoderma gangrenosum with pictures, because the exam from this topic will also come in DHA. Now, differentiation between the Crohn's disease and ulcerative colitis. In case of Crohn's disease, there is skip lesion, there is transmural granuloma, fistula and abscess are common, masses and obstruction, and perianal disease are present. In case of ulcerative colitis, it is noted that it is curable by surgery and it is entirely mucosal. There is no fistula, no obstruction and no perianal disease. So you have to see these features clearly. Another marker related question from ulcerative colitis: anti-neutrophil cytoplasmic antibody, that is ANCA, is positive in ulcerative colitis, whereas it is not positive in Crohn's disease. Anti-Saccharomyces cerevisiae antibody, ANSA or ASNA, is positive in Crohn's disease. So ASNA in case of Crohn's and ANCA in ulcerative colitis. Acute exacerbation of IBD, that is Crohn's disease and ulcerative colitis, are treated with steroids, mostly with prednisolone or budesonide. Treatment of IBD is anti-TNF. TNF is tissue necrotic factor. Adalimumab, infliximab, sortolizumab and golimumab, and anti-interleukin 12/23 and ustekinumab. Note that azathioprine and 6-MP, 6-mercaptopurine, are used to wean patient off of steroids. It means that when patient is using steroids, so to wean off the patient, azathioprine and 6-MP are used. Perianal Crohn's disease treatment is metronidazole plus ciprofloxacin. If fistula develops in IBD, then surgery followed by unresponsive treatment with infliximab is used. This is the end of today's lecture. I hope you like it. And if you are the first time viewer of my channel, please like, share and subscribe and wait till another videos.